So let's talk a little bit about catheter ablation, which is a technique in trying to address the underlying problem that's causing atrial fibrillation and then trying to alleviate that problem. So when we talk about catheter ablation, you want to compare it to some simpler treatments. So we look at things such as medications. These three graphs, what they're just depicting, are patients who the decision was made to try to control their rhythm. We don't want AFib to happen. Okay? That was the decision because the patients weren't feeling well when they were in atrial fibrillation. And so we said, okay, let's take half of these patients and we're going to give them the best rhythm controlling drugs that we can think of, the amiodarones and the sotarols that I mentioned before. The other group of the patient, the other group, I'm going to give a treatment called ablation. And we're going to watch and see how you do over time. And what has been clear for this study and many others like it is that over time, patients who are given medications tend to have a lot of recurrences. So what this shows, the numbers are small, but basically 16, 19, 17% of patients were still in a normal rhythm, no AFib, after about 9 to 10 months. Whereas if they had an ablation done, over 70% of the patients were still in a normal rhythm after 9 to 10 months after having the ablation done. So the catheter ablation keeps you in a normal rhythm much more effectively than any medication that's out there on the market. So a catheter ablation procedure is a minimally invasive tool, okay? Not the cutting and dicing that we just saw, but a minimally invasive tool which selectively destroys areas of the heart using either heating or cooling. And by doing so, you're able to restore normal rhythm and allow normal rhythm to persist. How do you get there? Okay, so catheters are placed through IVs that are placed in the creases of the legs. And through these IVs, thin little tubes are introduced into the heart. Now, most of the work occurs on the left side of the heart, and there's a thin wall that separates the right and the left upper chambers. So we poke a tiny little hole through that wall and introduce our wires into the left side of the heart. We can see everything under X-ray, and we can use a fancy sort of GPS system that also lets us know where these catheters are at all times. And then we do our work, pull everything out, and we're done. This is an example of the heart. These are the pulmonary veins that I talked about, those tubes that are draining the oxygenated blood back into the heart. And what we're trying to do is prevent this bad apple from causing chaos in the rest of the chamber. Because again, this guy has decided, I'm going to fire to my own beat, and you know what? Like a disruptive child in a daycare center, everybody else is going to follow suit, okay? So we got to get this guy to quiet down. So what we want is to stop the upper chamber of the heart from talking to the pulmonary vein electrically, okay? We don't want the upper chamber talking to the pulmonary vein, and we don't want the pulmonary vein talking to the upper chamber. So how do we go about doing that? This is a patient of mine that I operated on a little while ago. This is a representation of the upper chamber of the heart. The colored structures are those pulmonary veins. The brown dots are each place where I've actually placed a burn. And what's happening, you can see these brown dots are coalescing. Essentially, I'm creating a line. I'm putting the wall up, okay, without cutting the patient. And what you can tell, and I'm going to draw your attention to down here for those of you who can see it, but you can see a bunch of noise, let's just put it, right? There's a bunch of lines here. And then all of a sudden, all those lines disappear. That's when that vein has stopped talking to the rest of the heart, okay? That's the outcome that I'm looking for when I'm doing an ablation procedure, because that has said these veins can't talk to the heart anymore, and the heart can't talk to the veins. They still do their job. They're still able to drain the blood. So you're not affecting their function, but you're preventing the disruption. So I'm not expecting any of you guys to become electricians, okay? So don't get all caught up in this, but there's a very simple message in this picture. And that simple message is, hopefully you can recognize that there's a whole bunch of jibber-jabber going on in this middle section here, right? There's a bunch of lines that are fluttering away. But you can see very distinct, much slower lines up on top, okay? So what's happening here? This is actually a vein, one of those disruptive animals that we were just talking about, firing away erratically, trying to cause atrial fibrillation. But this is a patient that I've actually successfully ablated already. The patient stays in a normal rhythm because none of those signals can get out. Okay? That vein is like in a prison. You can't disrupt the rest of the populace anymore because this is doing whatever it wants to do, but it can't influence the rest of the heart anymore. So this is the outcome. This is why ablation works. You're changing the underlying way that the electricity is flowing in the heart as opposed to trying to cover it up with medications. You're altering the disruption. So the outcome that we're looking for, that I hope to be able to achieve for my patients, is this right here. So this is a patient who was given a small little device. It's called a loop recorder, and it was implanted. It's about the size of a AAA battery, actually cut in half, and it slips right underneath the skin. And what this recorder does is it's able to record the heart all the time. This patient was given one because he was having lots of palpitations, and we just couldn't figure out what was going on, why he was having so many palpitations. And so we put this recorder in, and lo and behold, what we learned was he was having lots of atrial fibrillation. All these blue lines that you see up there represent episodes of atrial fibrillation. So he had the kind that was intermittent. It would come and go, come and go. But when it came, his pulse was 170, okay? He felt horrible, all right? And it would last for hours. So sometimes he was lucky and he only had an hour. This is hours on a scale. Sometimes it wasn't. He'd be having episodes that lasted 8 hours, 10 hours, where his pulse is just racing away. You could throw all the medicines at him, it wouldn't work. So he felt horrible. So in mid-February, he came in and he finally had an ablation done. All right? And this was somebody who actually was already on a rhythm-controlling medication. The rhythm-controlling medicine wasn't doing the job for him. And so he came in and he had an ablation done this day right here. And then since then, you can see what the outcome is. No more blue bars. AFib has gone away. Okay? So it worked. So when it works well. Okay? Oftentimes, I will be asked, am I too old to have this procedure done? Remember that earlier on I told you this is a disease that becomes much more common as we get older. So most of my patients, many of my patients are in their 70s or their 80s who are suffering from this problem. From a safety standpoint, we looked at this and we said, okay, if we had patients who are over the age of 80, let's compare how they do with this procedure versus those patients that are under the age of 80. The blue bars represent those over the age of 80. The orange, under. What we can see is that their outcomes in terms of success are the same. Okay? The procedure usually is successful about 70 to 80% of the time. Okay? And if we watch patients over time, whether you're above 80 or below 80, doesn't matter. The durability of the procedure is the same. But most importantly, the risk of the procedure is the same. So patients, in terms of risks, and there's always risks when we talk about heart procedures. So the risks are low. They're less than 1% typically. If you add up every complication there is, it's probably in the order of about 4%. But it doesn't matter whether you're above the age of 80 or below the age of 80. Just yesterday, I had this beautiful 86-year-old woman who was maybe lucky if she hit 5'2", okay? She had this problem. She's been suffering. She's been in the hospital 4 times because of AFib and her heart going at about 160 beats a minute. And she just couldn't tolerate the medicines. We just did the ablation. She did fine. She's going home today. So it doesn't matter. The question is whether you're a candidate or not. So that's the big question, all right? Are you a candidate? And we'll talk about that a little bit. Let's just talk a bit about quality of life, right? That's what this is all about, right? You want to live a good quality of life that's extended, right? So from a quality of life standpoint, we've actually measured this as well. And we've looked at patients who've had successful ablations versus those patients who either didn't undergo an ablation or who were put on medical therapy. The higher the bar, the better quality of life. It's not even close, right? So the quality of life is tremendously improved on patients who have catheter ablation procedures. And there's a reason for that. One, it's an effective treatment. And so patients feel better because it works, okay? Two, is that you don't often have to take as many medications when you've had a catheter ablation done versus those that haven't. And we all know that medications come with baggage. They all have side effects, right? Whether it makes you feel bloated or dizzy or swollen or tired or whatever it may be. And the third reason is, unfortunately, the rhythm controlling medications that we have are just not that effective. probably work about 50% of the time. The newest one on the market, which isn't so new anymore, is a medicine called Motac. That came out maybe about 6 or 7 years ago. We were very hopeful that we would get a medication that would be much more effective. Unfortunately, it was a huge disappointment. So we just don't have great drugs yet that can help manage this problem. So this is the reason why catheter ablation is such a powerful tool. And it's for this reason that in 2014, the guidelines that help govern what I do, okay, changed. Catheter ablation used to be considered a second-line therapy, meaning that if you had atrial fibrillation, you had symptoms, we were obligated to give you medications, medicines that we knew may not work or may put you at risk for other organ toxicities, including liver damage and thyroid damage. But we were obligated to put you on those medications, try them first, and then see if they failed, then you'd qualify for a catheter ablation. But now, catheter ablation has moved towards what we call first-line therapy in certain patients. And so in individuals that meet the criteria, it may be considered as an option, as opposed to having to go on medications. So, are you a candidate? Chances are probably yes. If you have symptomatic atrial fibrillation and have been placed on one of these rhythm-controlling medications, but it doesn't work, you're still having symptoms, you're still having recurrences, or if the idea of taking one of these medications is something that you're not excited about because of either side effects or yet another pill, then you may be a candidate for this procedure. Again, the decision is on an individual basis, right? It's patient-specific. But most patients are often candidates for this particular procedure.